Welcome, everybody. We're going to start here at 10 a.m. New York time, and we're so thankful everybody's joining. We've got over 300 registered today. And of course, the webinar's title is Empowering Africa's Healthcare Systems, Understanding How Clinical Engineering and Biomedical Engineering Makes Its Impact. We've got a wonderful faculty today, and you can see it on the screen. Of course, Mr. Ashnafi Hussein from Ethiopia, Martha Tusabi from WHO Afro, Maladen Paluta from South Africa, Millicent Alu from Kenya, Dr. Mayombe Edison from Chad at the moment with WHO, George Bodu from Ghana. We're assisted by Fabiola Martinez. I'm Tom Judd from GCEA. Fabiola, the chair of IFMB Clinical Engineering Division, and Augusto Paulo Silva out of Brazil, but coordinating for Fiocruz, Portuguese-speaking countries of Africa. So welcome to the faculty, welcome to all of you. And we've got an announcement about today that we will make now. Caleroy, first some instructions, please.
Welcome, everyone. We're very happy to have you in this webinar. Please note that in today's webinar, we are sharing two presentations simultaneously, one in English and one in French. On the top of your screen, on the view button, you can choose which of the two shared screens you would like to see. There is also simultaneous translation with captions from English to French. And also remember at the bottom of the screen to use your Q&A button in order to add the questions you would like to address to the faculty. For any other communication, please reach us through the chat. Thank you so much.
So I'd like to take this opportunity, first of all, to say good afternoon, I guess, to most of you listening in. This is the great opportunity that you see before you. I'm not sure how many of you are aware that there is a global clinical engineering journal. If not, please take time to find out how to access this. It's open access. You can read all the articles at your leisure, download them, share them with colleagues. You can also go back in time and look at all the archives of past issues. But what's particularly exciting and relevant to this webinar is that we are going to have a special issue of this journal that will focus on Pan-African activities. And that's where you come in, where you have the chance to showcase the work that you're doing, but also contribute to global and regional agendas in clinical engineering and help advance clinical engineering around the world, but also ensuring local relevance. So we invite you all to consider, and perhaps if you haven't started yet, start thinking about a publication that you could prepare for this journal. Thank you. Over.
Caleroy, as I change slides here in a moment, would you go on and give the instructions one more time? We've had a number of people joining here in the last minute.
Please note that in today's webinar, we are sharing the presentation in two languages, both in English and French. If you would like to see one of the two shared screens or exchange between them, there is a button on the top of your screen which says View. Or if you press that, you'll find the option on which shared screen to view. At the same time, we have a simultaneous caption translation at the bottom of your screen from English to French. Please add your questions to the faculty in the Q&A button, which is at the bottom of the screen. Thank you.
Thank you, Caleroy. And at the beginning, just a minute ago, for those just joining, we showed the pictures of the faculty today, and we will certainly share this presentation in English and French to you afterwards, and perhaps Portuguese. So we have a Pan-Africa Clinical Engineering, Biomedical Engineering team, and Ashnafi, tell us about that.
Thank you so much. So I would like to take this opportunity, to thank GCEA for organizing this wonderful webinar, and just to oversee how this Pan-African CEBMET team is established. It's basically encouraged by GCEA and IFMB CET division, and it's been created in recent years which includes many African countries who speak English, French, Portuguese, and Arabic, more than 47 countries. And as you all know, we as clinical engineers, we know we design, we develop, we maintain, we manage medical devices, and through the professional federation and the international community like GCEA, we get connected just like what we have today. And there is also a connection through different international health organizations like the World Health Organization and different organizations working on clinical engineering area. So we have this issue, especially when it comes to medical device management, which is very, very critical to Africa. So GCEA has taken this issue to the next level, just taking into consideration how clinical engineers can solve problems that's happening in Africa by establishing Pan-Africa GCEA team. And we as professionals, we have a connection with different professionals, and what we have done so far with WHO and EMRO regions is so wonderful. So I believe, you know, we can continue to develop further, and we encourage especially many African countries to join GCEA the quickest possible so that we can have the results that we need when it comes to you know, accessing and enhancing clinical and biomedical engineering in Africa. Thank you so much.
And we're going to have Fabiola Martinez tell us about this slide.
Well, good day, everyone. Thanks for coming here and joining us to this fantastic webinar. As you know, clinical engineering is not quite new. We have over 50 years of working hard in the hospital and other fields, and we have had many important points to highlight along this history. One of them has been the recognition from the World Health Organizations in the 207 resolutions concerning health technologies management, and the assemblies from 2020 and 2021. In those events, biomedical and clinical engineering were called as important and strategic roles in the health care environment. So the need of clinical and biomedical engineer for further managed health technologies defined as medical devices, PPE, oxygen resources and delivery, and now digital health tools, has been a very important point that has to push us to the spotlight into the healthcare scenario. So the clinical engineering community has been growing in the last years. We have a worldwide footprint, and the key activities from this has been the International Clinical Engineering and Health Technology Management Congresses. We have organized 5 so far, and the last one has very important for us because we had the opportunity to increase our footprint over the world, but also to have a networking that has been strengthened our capacities and acknowledge the a specific role that we have into this challenge of healthcare. So the stories and the evidence from the global community has been recorded in different ways. For example, the response from COVID-19 from clinical engineers, the survey, the second version of the survey in 2022 regarding the global priorities or the regional priorities in HT and clinical engineering, the calling for actions that we have developed to apport and to contribute to these endeavors, and now the knowledge of the Africa region as a very, very important one to develop the clinical engineering. The clinical engineering role has proofs of this role, the growing role that we have over the different disciplines in clinical engineering and in the world. So we have the opportunity to push over even more this role and continue working together, making networking and making a better job for the patient care. Thank you.
Thank you, Fabiola. Dr. Edison Mayombe from Chad.
Hi everyone. Thank you, colleagues, for joining this wonderful webinar. Actually, what I can say here is that this a huge community of clinical engineers is the combination of GCEA and IFMB in the clinical engineering division. And what we can say is that many things have been done, and especially during the fifth International Clinical Engineering Health Technology Management Congress, which happened in India. The Pan-African leaders presented a good part of work, and this was, they presented about 25 from 25 countries, and we made 36 presentations and 16 posters, and this was around 20% of the presentations which was done at that day. So I can say that this clinical engineering community is giving a great impact in African region. And as we can see how people are joining and being interested, I think the future will be more bright and brighter. Thank you, Tom. Over to you.
Thank you, Doctor. And Callie, just before I talk about this, just briefly, actually, Mladen's going to tell those instructions one more time. We're having great attendance and several people have just joined.
Yes, of course, sir. If you haven't heard that already, we are offering a simultaneous presentation of the PowerPoints in two shared screens, both in English and French. On the top of your screen, there is a view button that you can choose which shared screen you will view. At the same time, we are offering a simultaneous caption translation from English to French. And please remember to add your questions to the faculty during the webinar in the Q&A button on the bottom of the screen. Thank you.
Perfect. Mladen?
Yes, thanks, Tom. So for those of you who have joined late, my name is Mladen Paluta, and from Cape Town, South Africa, southern tip of Africa. So I greet you. And as you all know, Africa is a huge continent. And so there's a regional community of clinical engineering practitioners that is yet to come to its full potential, and that's the exciting opportunity. But we're also part of a global community, as you can see here. So between the IFMBE Clinical Engineering Division and GCEA, we have over 1,000 collaborators from over 200 countries. And as you can see there, the list of different profiles of collaborators and practitioners, which includes medical physicists, technologists, technicians, and basically a broad sweep of different aspects of society. And it's just really to underline the global nature of our community. And also, I think it importantly underlies that it does take a village. So when we talk about healthcare and healthcare delivery, and even health technology management, it takes a village in the sense it requires complementary skills. And so as part of this global CE community, there's an underlying network of expertise that seeks to advance health technology management, clinical engineering, and biomedical engineering globally, but also regionally. And so we look forward to much more input from colleagues in the African region and collaboration across countries, so that together we can face the challenges that face our region. Thank you.
Thank you, Mladen. So this is a bit of a busy slide, but I'll go briskly. So on the right, on the left, just reinforcing what we've defined about clinical engineers. Also, many of your countries call biomedical engineers who serve at the point of care. And these definitions come from WHO. So we manage health technologies through their life cycle, according to WHO methodologies. We innovate new models and tools for care, including in recent years, digital health. We ensure appropriate health technologies on the front end in the selection and deployment process, and then ensure sustainability through their life cycle during use. It's so important to work through national clinical biomedical engineering societies to develop capacity building at country and regional levels. And as a result of all that, we've measurably improved healthcare safety, quality, and clinical outcomes. On the right-hand side of the slide, before I get to this capacity building framework quickly. So what has WHO done as a foundation for all that? They measured over 800,000 clinical engineering practitioners back in 2018. That includes engineers, technicians, technologists from 130 countries in that 2018 measurement. But we in the global community have shown there's over 1 million of us in 200 plus countries practicing today. And during COVID, the global community of CED and GCEA had actually really closer to 100 best practice webinars with 160 countries attending that really fueled the growth of our profession around the world. And its recognition, we joined with WHO's evaluation and its compendia of innovative health technologies for low resource settings in the COVID years. And many of us have joined the WHO Strategic Advisory Group for Medical Devices that under Adriana Velazquez's leadership is driving a lot of improvement. Now in the middle here, this capacity building framework that we developed in recent years, don't have time to go over all of it. I'll tell you there's 3 buckets. There's a bucket of knowledge, a bucket of investment, and a bucket of competencies. Knowledge, typical education, ongoing training, perhaps internships, credentialing, but more recently, digital health and innovation are part of our knowledge base. And investment is your country getting most of its medical equipment, for example, from donation? Is it getting from purchase? Is it driven by your Ministry of Health as it is in many countries? What kind of clinical engineering departments and how do you manage inventory? More recently, how are you measuring quality and safety as a result of that at various levels around the world? And certainly competencies, we all know there's a scope of devices and so forth to take care of. But what is your relationship with clinicians and the rest of the healthcare team? Do you have a national society driving improvement efforts? Are you developing leaders? And are you involved ideally in policy, regulation, and legislation? So we'll keep moving here. Take it away, Millicent. What do you see here, Millicent?
Great. So thank you so much, Tom. And hi, everyone. So this is a survey that was done in December 2022, the global survey about the knowledge, the body of knowledge of practice. And as you can see, though, Tom, I'm really struggling to see it. But as you can see, we had different representations and different observations from different groups. So we had like young professionals, that is under 40 years of all 50% giving feedback. And then we had like about 30% of women in the CE. And then we had nearly about 50% of the clinical engineers, practitioners with less than 10 years experience. And we also had 15% associate degree members, undergraduate being 35% and masters 40%. So out of this, we can actually see that we had 237 Africa responses from 30 countries. That was about 27% globally in total. Yeah.
Thanks,
you so
Melissa.
much, Tom. Over to you.
Such a robust response. Out of nearly 900 around the world, nearly 240 responses from Africa. All right, Mladen.
So if we dig down a bit, you will see here that circled were the priorities that came from colleagues in the African region, headed by maintenance, followed by quality, and so on and so forth. But if we stop and think about it, they are all interrelated. And if we're looking at clinical engineering practitioner in a hospital environment or healthcare environment, he or she actually requires competencies in all of these areas, or at least a knowledge of all of these areas. So this is a good indicator, but each of these, as I said, can be broken down into subtopics, because one can talk about the quality of maintenance, and one can equally talk about the role of maintenance in quality healthcare. So I think it's just a starting point, a point of departure. But I think what we as a community of practitioners in the African region need to identify gaps, and those gaps might differ from sub-region to sub-region and even to country, but essentially to create that melting pot of expertise that is able to grow collectively together, so that the gaps in capacity and capability in all countries across Africa are improved. And I think GCEA and IFMB CED are well positioned and, of course, committed to supporting that endeavor. Thank you, Tom.
Thank you. So what happened during COVID, Fabiola?
Well, a lot happened during COVID, but mostly I think it's important to highlight that clinical engineers around the world were perhaps one of the most dynamic and agents of changes during COVID-19, due to the needs from technology to adapt to this new situation. So we had a lot of work during these years. And fortunately for the community, the clinical engineering community, we had the opportunity to share these experiences and lessons learned from this time. So over the pandemic time, we had developed over 19 webinars dealing with the specific topics that were at the top of the wave of from the COVID-19 pandemic. Many of the stakeholders wrote about the reliance on health technology and highlighted the importance of the innovation deployment and support the continuous demands of the pandemics were presenting. As a result of this, we had various articles on the Global Clinical Engineering Journal, and specifically in December 2022, there was a very important point by the publishing of this article, The Growing Role of Clinical Engineering, Emerging Technology at the Point of Care, that enhance and makes it put on the table that we as clinical engineers have the potential of making very important changes on healthcare. No, and after that, in the last Clinical Engineering International Conference, we had the opportunity to hear these experiences, specifically in the different tracks that we were sharing along these days, in capacity building, measurement, credentialing, and policy development. So with these documents that you can consult into the GCEA webpage, you can see that there are a lot of things that we can do, not only for response to the emergencies, but also to be ahead on this and make the difference into this field. So I invite you to visit these places so we can appreciate this role. Thanks.
Thanks, Fabiola. And we're, of course, trying to keep moving here to give time for Q&A and discussion at the end. Mladen?
Yeah, so you'll see there the first point that the Global Journal in December 22 has an article which I believe Tom and Yadin David are co-authors. It reviews the evolution of the CE profession since 2020. So you might say, well, what happened before 2020? Didn't clinical engineering exist then? Well, I mean, of course it did. Some of us go back to the late 1970s in terms of our early involvement with clinical engineering. But I think the point here is, as Fabiola kind of shared and emphasized, that it is really 2020 that in many ways put clinical engineering practitioners front and center in terms of the COVID response. Just as an example, it was our clinical engineering colleagues in Italy who first advised us and informed us of the important role of non-invasive ventilation for treatment of COVID. And as you probably know, in many cases, it was non-invasive ventilation that actually saved thousands, if not millions of lives. So clinical engineering has really been in the limelight to a great extent. And if we think about health technologies and global health technologies, it's now accepted that oxygen is one such vital technology, but then so is water. So I think there's a great opportunity to think about health technologies more broadly and how their availability and accessibility impacts on health and health status of communities. So it's really a great opportunity and almost an open agenda for clinical engineering practitioners to identify priorities in their countries, in respective countries, and then collectively to address the many needs, whether they are national, regional, or global. And we are part of that global body. And at the same time, we will be developing both the body of knowledge and the body of practice for clinical engineering, or biomedical engineering as it's called in some African countries. So obviously social media plays a very important role, and we give credit to people like Kaliroy, who have really made these platforms available to us to empower individuals and groups, and also to provide a ready form of communication. And one last point is, as I've mentioned before, we are not alone. It takes a village. So we also need to be conscious of the need to collaborate with other health professionals, because together we are better. Thanks.
Thank you, Mladen. So as a result of this global reliance, there is a call for action for our profession that basically is three things: education of the workforce, national health technology policy, and the importance of national and international alliances and partnerships. What do I mean by education? Well, you know, as digital health tools flow in alongside traditional medical devices and so forth, we need to relook at how workforce delivers care. And I'm talking about clinical engineers and nurses, say, for example, could work together in new ways that are not presently perhaps being used in healthcare delivery, so that we handle some of the technology pieces and the use of the device pieces, and the nurse gets the result of that use of the devices and digital health tools and is more available to the patient. So there's some things going on in the background around the world to test that out, new ways to work with clinicians like nurses to deliver high quality care. We learned during COVID, you really need a national health technology policy. There's some examples of that we'll share a little bit later in this presentation. And you know, we need to work on alliances across health sectors, industry, academia, and NGOs together. So more to say about that. Ashnafi and I will talk about some of these stories. Ashnafi, you want to mention some thoughts here? So these are some global stories of evidence.
Yes, thank you so much, Tom. Just to add a little points on what Mladen has already presented, especially on the health technology and to these stories. I think the world is growing smaller, where the technologies are advancing, and we're just coming to a community that includes not only clinical engineers, biomedical engineers, but like you said, many professionals can join GCEA, and that's the beauty of GCEA, that can incorporate many professionals. So as at the global stories, you know, Ministry of Health professionals, and especially GCEA and FMBCD division, you know, they have done a lot of activity with webinars, and WHO has taken, you know, a great responsibility, especially in fighting COVID. During that time, issues related with medical devices like ventilators, oxygen sources, and establishing medical device units, and providing lots of evidences and documentations, supporters, and increase, you know, the medical device to include not only the medical device, but also the sources and the delivery tools, as well as the digital health tools to that area where many professionals can, you know, solve COVID during that time. So these are some of the key global stories that we have seen during the COVID time. Over to you, Tom.
Very good. I think we'll keep on moving here. I'm going to talk very quickly. Once again, we're leading towards what happened in Africa. What are the success stories in Africa? We're going to talk about those in a moment. But I'm going to mention very quickly a couple of stories from outside of Africa during the COVID period. One of them was in the UK, in the United Kingdom. Our colleague, Dan Clark, who gained Officer of the British Empire as a result of leading the clinical engineering effort in that country, where the National Health Service was sending home pulse oximeters to patients all around that country and countries for the purpose of measuring your oxygen saturation during COVID, so that as you saw the oxygen sat begin to dip before it got too low, patients could seek medical help. And the clinical engineers there ensured the accuracy of those pulse oxes that went to the homes, and it improved outcomes as a result. Over on the right, over in China, our colleague Miss Lu Jiamin, introduced digital health all over healthcare delivery in an inpatient setting. And so you could talk with your practitioners before you went in through social media. You would be driven through getting care in the hospital with digital health tools while you were in. And then afterwards, you could also follow up with the practitioners with digital health tools, improving outcomes. So more to say about that perhaps later, but let's take it here. George Bodu, tell us about what happened in Ghana during COVID. What's so significant is many of you are challenged in your countries with getting Ministry of Health or government recognition of the profession. And we all know that government recognition drives many of the resources that then flow to our profession to help us to do the job better. And so what happened is clinical engineering gained recognition as a health profession in that country during COVID. And of course, that's driving many new opportunities. Yes, George.
All right, thank you very much. So in 2011, before COVID in 2011, there was some issue of the reclassification of jobs in the health in Ghana. That is the single spine implementation policy, which was implemented in 2011. And during that implementation, clinical engineers were relegated to be as a non-clinical group. And in Ghana, they classified the workers in the health sector into two categories. That is those under clinical category and then those under non-clinical category. And the purpose for that classification was that those who don't have direct patient care are considered as non-clinical category. So when they did this classification, the Ghana Society of Biomedical Engineers actually took it upon themselves to renegotiate with government to change clinical engineering as a non-clinical group to a clinical group. And this struggle took us about 5 years for us to complete the process. And we did this through a series of activities like sensitization and awareness creation about clinical engineering, and then also engage the Ministry of Health through the negotiations where we finally had the opportunity to do job evaluation. So based on our job evaluation assessment, they saw that yes, biomedical clinical engineering is actually a clinical profession. And so based on that, we gained recognition from Fair Wages and Salaries Commission for us a health work, biomedical clinical engineering as a health profession within the health sector. And they aligned the salaries of clinical engineers to that of nurses and then allied health professionals. And then moving forward, the discussion was whether we belong to allied health or engineering or both.
And George, we're going to move on in 1 minute.
We've had a series of discussion afterwards. And currently, as I'm speaking, the Allied Health Professional Council.
Yeah, we need to move on, brother. But we got the story, and it's a wonderful story. Millicent, can you tell us about Nest 360? Go ahead.
Thank you so much, Tom. Thank you so much. So Nest 360, I just want to give us a brief overview of what Nest 360 has done to impact the health technology management, especially in the newborn healthcare space. So one of the things that Nest 360 has been able to do is streamlining the education system, whereby the biomeds are empowered to ensure that they understand the devices in terms of the troubleshooting, the PPM, and even the breakdown maintenance. And apart from that, apart from just training them, Nest 360 has been able to offer working tools to the biomeds, typically going and buying the device tools, the screwdrivers, the testers, and all that to be able to enable biomedical engineers to work. And on top of that, we've also, Nest 360 has also been able to ensure that the biomeds and the clinicians are all trained together in such a way that there's a very good collaboration between the two teams, because we noted that there's a very big communication gap between the clinicians and the biomedical engineering. And one of the things that we are really fostering is to ensure that this proper communication so that we do not miss equipment because the communication was not done well. And so training these two teams together has really ensured that there's a very good collaboration between these two teams and the devices are kept at optimum level of operation. And then finally, the main thing that I would also say is that, as we all know, Africa is really struggling to ensure that the biomedical engineers are employed. And with this, Nest 360 has provided employment opportunities for the biomedical engineers at various in various countries where we are. And of course, by doing this, at the end of it all, we've been able to really increase accessibility to newborn devices with the highest uptime that is required. Actually, we record a 90% uptime for our 99% uptime for our devices, and for other devices, we have recorded 90% uptime. Thank you so much, Tom. Over to you.
Thank you, Millicent. So what you've heard so far, folks, from the Afro region is recognition at the national level of our profession. And then on the issue of maternal child health, which is large in every country, here's a 5-country study where we're really making a difference. So Dr. Mayombe, WHO, first in DRC, now in Chad. What happened during COVID with you, sir?
Thank you so much, Tom. I will share with you what happened during COVID-19 in DRC and in Chad, where I have been working with WHO. And in DRC, we did a study on the maintenance and functioning of oxygen concentrators. And during this study, we found that many parameters was not good. And the conclusions was that the low functionality of oxygen concentrators increases patient risk and shows the need to implement a provincial strategy for the health technology management and its integration into the regional health development plan. And actually this has been done because now in North Kivu, locally, we have the list. Chad, we had also a good success story. During COVID-19, when we were about installing new PSA plant, we started a new strategy of repairing and maintaining those oxygen concentrators which was broken down. And this was a very nice experience because more than 100 technicians can save more patients where there is no PSA plant, because in our countries there are many oxygen concentrators which are not being used, or are broken down because of because of lack of maintenance.
Dr. Mayombe, we've lost you, but I'm going to move on. But you see a wonderful story besides the recognition, besides the maternal child health being addressed, the COVID-specific issue of respiratory devices, notably oxygen concentrators being addressed in 2 countries. And the last story, very quickly, I'll mention about is this 5-country West Africa study about what are we doing with our structures of biomedical and clinical engineering in those countries to increase the possibility of innovation. So this is both our academic side and our practical side of clinical and biomedical engineering working together. And what the conclusions were, it's still pretty early to really generate a lot of innovation, although some of the people online today are part of the AMTZ World Health Innovation Fellow Program. They're now over in India. There's about 25 fellows over there, and about 20 of them are from Africa. So maybe that's something we can talk about later, but this study showed the importance of your national clinical engineering, biomedical engineering that serves at the point of care associations to bring about improvement and innovation. So we are nearly done, so we want to get to Q&A and take it away, Millicent and Ashnafi. Millicent, so there was a big regional meeting for Sub-Saharan Africa in Nairobi last September. Tell us about that.
Yeah, thank you so much, Tom. So once again, hi everyone. So we had our very first regional meeting in Africa, in Nairobi, Kenya, 2023. And we had quite a lot that we discussed as a region. And one of the key areas that I'll just mention here that is affecting all of us, you saw from the presentation from Ghana and even the presentation from DRC, it actually points out to the fact that we do not have a robust health technology management policies in Africa to govern our practice. And so as a region, we concluded that we really need to work on creating awareness with the government bodies, the ministries of health, to be able to develop relevant health technology policies to support us in doing our work as the clinical engineers. And the other thing that we really also noted was the lack of regulation that cuts across, and that is still really under the HTM policies. But we noted that majority of our professionals are not regulated. So the very major key takeaways, and even as we listen to this, is for us to all create awareness for the implementation, for the development, and even for the revision of all the existing and non-existing health technology policies across the region. Thank you so much. Over to you, Tom.
Go ahead, Ashnafi.
Yes, thank you so much. So in addition to what Millicent has already said, I think we need to just put it in a way that this was the first meetings of African meeting after COVID, because we had a lot of African meetings before that. So after COVID, it was a successful meeting organized by GCEA and IFMB and AMEC of Kenya, where we had participants in person in Nairobi, as well as attending from online. And we had more than 62 presentations, which was so successful, taking into consideration the limitation that we have, especially the infrastructure. And we just come to the conclusion that we need to come together as Africa. It's not about just societies or only organizations that we're talking about, but we as Africa region, as a Pan-Africa, we need to come together and we need to work closely with GCEA. And I will take this opportunity to call all Africa members and joining and attending this webinars to join GCEA. GCEA, please join GCEA. Please contact GCEA for joining, how to join GCEA, and let's make Africa moving forward in our profession to the next level. Thank you.
And Emily from UMATEM, I know you're out in the audience, and I'm going to try to unmute you so you could talk about the French meeting in Benin, if you can.
Yes, sorry.
And go ahead and answer in French, if you will.
Ah, ok. Oui, donc bonjour à tout le monde et merci à tous les francophones qui se sont connectés aujourd'hui. Donc, il y en a peut-être un certain nombre d'entre vous qui avaient participé aux journées biomédicales du RESAOC, les premières journées biomédicales du RESAOC au Bénin l'année dernière, donc organisées en partenariat entre UMATEM, le réseau hospitalier d'Afrique, de l'océan Indien et des Caraïbes, le RESAOC, et l'Association française des ingénieurs biomédicaux et la Fédération hospitalière de France à Cotonou au Bénin en octobre l'année dernière. Donc c'est un colloque qui a balayé en fait un très grand nombre de sujets sur la gestion et la maintenance des équipements médicaux en Afrique, dans les établissements de santé africains. On a eu aux alentours de 350 personnes en présentiel et 50 personnes en visioconférence, donc ça a été un très grand succès. Voilà, on va très prochainement normalement sortir les actes de colloque enfin, donc on les partagera avec tous On pourra les partager avec tout le monde via GCEA. Voilà, on sera très content de pouvoir partager ça avec vous. Et alors à noter, hein, je remonte l'information là pour Tom, Jude, pour tous les membres anglophones. Il y a vraiment des besoins de traduction en français, hein. Il y a beaucoup de personnes là dans le chat qui demandent, voilà, les sous-titres, c'est peut-être un petit peu compliqué à avoir, donc c'est sûr que pouvoir faire des webinaires aussi en français avec une traduction d'une manière ou d'une autre, ce serait super. Voilà, merci Tom pour cette opportunité.
Very good. Thank you, Emily. And there was also, there's a movement around, and sorry about the slide being wrong, from Portuguese speakers. So we introduced Augusto Paulo Salva. Augusto, talk about what you would like to see done.
Thank you, Tom, and thank you all of you. My name is Augusto Paulo Silva. I'm here in Brazil, Rio de Janeiro. I belong to the National Institute of Public Health of Brazil, Minister of Health of Brazil. And to say that Brazil is advocating for the development of this area in the African continent, because since 2009, we realized that the area is underdeveloped in our country with which we develop technical cooperation. This is
And
why
Augusto, maybe also share in Portuguese. I'm sorry to interrupt, but we want to include everybody. Also share your story in Portuguese in a moment. Go ahead.
Do you want me to shift to Portuguese?
Yes, sir. Go ahead.
Então, eu estava a dizer que daqui estou no Rio de Janeiro representando a Fiocruz. Como sabem, o Fiocruz é um Instituto Nacional de Saúde Pública do Brasil, do Ministério da Saúde do Brasil, e desde 2009, no âmbito da nossa comunidade dos países de língua portuguesa, tomou-se a decisão a nível dos ministros da saúde para que todos os países africanos de língua portuguesa e Timor-Leste tivessem os seus centros técnicos de instalação e manutenção de equipamentos. E desde então estamos a trabalhar, a advogar para que isso aconteça. Infelizmente isso ainda não aconteceu como gostaríamos que acontecesse, mas de qualquer das formas, juntando-se a essa iniciativa agora, nós queremos, de facto, apoiar e trabalhar juntos. Para isso, a Fiocruz está a abrir um novo escritório, o seu escritório, em Addis Abeba, para estar mais próximo da União Africana e, assim, poder cooperar tecnicamente com todos os países, não só aqueles que falam o português, mas também todos os países africanos que o desejarem. Muito obrigado por esta oportunidade.
Thank you. And I know we've got friends from the Eastern Mediterranean Regional Office of WHO from those countries in North Africa. Perhaps there's not a moment right now to share, but we want to hear your stories as well and want to encourage that and work with your regional office and Mohammed Wibi, that is the representative there, like Martha Tusabi is in Afro in Brazzaville. So we're going to wrap up here and still try to answer some questions, I hope. So just before that, Mladen, you gave a pitch at the beginning. Can you tell folks again about the special issue of the Global Clinical Engineering Journal?
Thanks, Tom. So this is an invitation to you all to think about contributing to this journal. If for some of you, it could be the first time that you've published. If you're unsure about what to do and how to do it, feel free to approach us. But I think it's a great opportunity for all of us to really place the African agenda on a global stage and to explore opportunities for collaborating both within Africa and between Africa and other regions. For example, one idea could be a position paper or a number of position papers on topics that we feel of great importance to us. And we got a sense of what those were in the results of the global survey. So please do go and visit the journal site. Access, as I said, it's open access, previous publications so that you get a good idea of what has gone before. But please feel free to contribute and think about how you could contribute to this great initiative. Thank you.
Folks, we have a lot had a lot to talk about today to show this evidence from the Afro and EMRO regions, as well as for around the world. You know, the webinar is due to end in 5 minutes. We can go a bit longer for those that can stay. There were this is an all play from the faculty, not just from me. There were 2 questions that came up at least, and I know there's many others through the chat and the Q&A. One of the questions was, can the National Clinical Engineering or Biomedical Engineering Society, how can it be connected to GCEA and CED, and how can we speed up communications and assistance? And one of the ways that can happen is through getting access to the training. We talked about, you know, you heard different numbers, 50, 90, 100 webinars the last 4 years or so. Many of those webinars with recordings and slides are downloadable from the GCEA website. And Calroy and others can put that link in the chat as we go here. And there were, you know, many other from CED. I know they're undergoing a website change, but all of those are available from a Dropbox that can be sent to you. So we can get you all these 100 webinars and that information. One of the things we want to do as we move, and those webinars had best practices from different regions of the world. As we move forward, we want to take snippets of those webinars, video snippets and so on, and blend in the African stories, the Afro and EMRO stories, so that you can create tools for your perhaps month-to-month society meetings, so we can help you build your societies. So that's an answer to a couple of those questions. But any faculty member, jump right in. For instance, let me pick on my sister Millicent. There's so many resources being developed for Sub-Saharan Africa. Millicent, you want to talk about some of them?
Yeah. Thank you so much, Tom. So we have quite a number of resources that we've actually developed, and maybe going as Nest 360, if you go to our website, you'll be able to see quite a lot of them for the trainings, you know, for the career growth and many others. But again, even as the Association of Medical Engineering of Kenya, we have been able to really develop quite a lot of resources, and we have a lot of seminars and a lot of webinars and trainings where we also empower and just, you know, inform the members of the Clinical Engineering Society on what's going on and even how to be in the field. And one, finally, even as I talk about the women in biomedical engineering, we've also come up with quite a lot of initiatives to support women in this particular career. Yeah, so as Tom rightly says, there's quite a lot of resources that we can actually get through different pages to be able to support us even as we continue in this profession. Thank you, Tom.
Other faculty members, as you feel led. While people are opening their mics, I've put in the chat that UMATEM that you heard from Emily, and the AFIB Society, Clinical Engineering Society in France, has many webinars in French that you can get access to. Our colleagues in Brazil, ABE, and I'll put the name in here in the chat, CLIN, ABE CLIN, have many webinars in Portuguese to share. Over.
Yeah, well, I'd like to mention that, okay, we may have a lot of resources, and most of them are developed in such a way that people can reach them from the internet. But we know that the region has this is an issue for the region. No, not all the countries have the quality of the connections that allows them to reach to these resources. So considering this point and trying to help, in CED we are thinking of developing a way to make such a hub that all the information can go to this point, and from this point could be shared to the other points in the region in such a way that all the people can reach these contents. So we can work together, CED and Global GCE, to work on this in this project, and maybe to share it into the other regions. But I think if we can do it in Africa region, we can do it in all other places. So we can talk about this.
And
Go ahead, Ashnafi.
Yes, thank you, Tom. So in addition to what has been said, I think when it comes to resource, I think GCEA is more professional community than the organization that we know in other area. So I think it would be very nice to use all social platforms like WhatsApp or other social platforms to share, resources, as well as I think we have all the GCEA higher officials like Mladen Poluta, the president-elect, Tom Jude, Kali Roy, Fabiola. So I think if you can drop your contact so that people can easily get in resources, and if it's possible, we can add those people to the WhatsApp chat so that resources can be shared. So we can use the different online tools to share resources. Thank you.
So good point, Ashnafi. All of us can put our contact email perhaps in the chat. Any other comments from the faculty members? And perhaps closing comments as it's after the hour. What I've been showing on the screen is more information beyond the scope of our ability to discuss it. More a view of the many presentations from Africa during the Congress last year, many presentations from the Nairobi Sub-Saharan Africa English-speaking program last year, and then, we got 4 years of the Global Clinical Engineering Journal with many tools available through there. So, and we thank you for your time today. Mladen, any last words, brother?
I think it's a great turnout, Tom. So there are over 100 participants. Obviously, we would like to hear more from each of you. So let this just be the beginning of greater interaction, both with GCEA and the IFMB-CD, but also with one another, country to country. I see Francine from Rwanda has just joined, so welcome, Francine. We need to set up collaborative channels so that together we can advance the global clinical engineering cause, the regional cause, but most importantly, make a positive impact on healthcare delivery in our respective countries. Thank you.
And I'm putting in what we've said throughout the program today is that the presentations in English and French and the recording will be posted on the GCEA website. Many of you know from the recordings, there's a simultaneous transcript available from Zoom that can be tuned to a different language. So you can read the transcript as it goes in the language of your choice. Thanks, everybody. Appreciate your time today. Hope this has helped. More later. Bye for now.
Thank you. Asante.
Thank you to everyone.
Muito obrigado,
Merci.
muito obrigado.
Merci,
Um abraço ao
obrigado.
Brasil.
Merci. Asante. Ciao.
Bye-bye.